Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a couple of procedures in this compilation video, and this is of patient one. Now, both patients were guilty of misuse of Q-tips, so cotton swabs. In the UK, we call them cotton buds. And so in both instances, this wax is really impacted. And in the first case, you can see the wax has been there for a while. It's matured, it's oxidized, it's quite dark in appearance. There's quite a few matted hairs. So these hairs shouldn't be in this part of the ear, because these hairs, strands, should only be erected from the outer third of the ear canal. So the outer third, the cartilaginous portion, it contains a layer of skin that's 3-ply thick. You've got the epidermis, the outer protective layer, the dermis layer, where you've got the collagen, the elastin, but also importantly these hair strands alongside the sebaceous glands and the ceruminous glands, which secrete sebum, and the oily sweat, which eventually form into wax, and the subcutaneous layer, the hypodermis layer, which is a fatty tissue layer. Whereas the bony part of the ear canal where we're working in, it's void of the dermis and the hypodermis, or also known as a subcutaneous layer of skin. So there shouldn't be any hair strands here. So we know this has really been pushed in, these hair strands as well. So they might have come loose in the ear. So the hair follicles, the hair strands may have detached and been replaced by another layer of hairs, but they shouldn't really be here. So this is where the earpick really comes to the fore. Suction wasn't really going to get me very far, I don't think. So I did immediately start with the suction. And because of how impacted and occluded this wax is, right up against the canal wall, it's really compressed. Getting an ear hook or even the RAI Keratin in between the wax plug and the canal wall would have been quite tricky. But with the earpick, I'm able to glide in between the wax and the canal wall, and it's got a very narrow pointed tip. So of course you've got to be very gentle with this as well. You don't want to be poking through anyone's eardrum or lacerating or scratching the side of the ear canal wall. So I think with the ear pick, when it's all being launched very, very soon now, we've got a proposed date for all the new instrumentations to be available for specialists to purchase the second week of March. So we're only a few weeks away at best. But I would say that there should only be really skilled specialists, experienced specialists, be using the RAI pick to begin with, because it has got a very, as I said, that tip as well. It's not, with the ear hook, it's got a 90 degree base, so it's like an L bend. So it's very difficult to penetrate the tip of the ear hook into the eardrum. You can, though, on the canal wall quite easily because of the angulation there. There's a slight attic retraction to the top portion of the eardrum. There is a retraction there. This patient has got negative middle ear pressure due to a blocked eustachian tube. So the eustachian tube is the orifice that connects the middle ear cleft, so the cavity behind the eardrum, to the back of the nose, the nasopharynx. And at normal resting state, the eustachian tube is shut, but during the course of the day, in fact, about 4 or 5 times a minute, without us even realising, when we swallow, yawn, or chew, the eustachian tube, the muscles at the base where it connects to the back of the nose, they contract and they momentarily cause the eustachian tube to widen and open. And during those brief moments, the air pressure can equalise, because we want the air pressure equal behind the eardrum to the atmosphere. So that's when the eardrum is at its most mobile. That's when we hear the best. So patient one had been successfully treated with the ear pick. Again, this patient had been using a Q-tip. You can probably see the indentation. This wax is not as matured, it's not as dark, but it is very dry. And I actually end up removing this just with suction. With patient one, I just felt, and sometimes it's with feeling, when you're in the ear and you can feel the wax, which obviously you can't do on screen when you're watching. You just have this intrinsic feeling that it's not going to come away with the suction, even if you put drops in. But in here, I kind of feel this is going to come away. I just get that kinesthetic feel. So I've just put some olive oil in. So whenever, and again, this is quite deep in the ear. It's in the centre, in 2/3 of the ear canal. Wherever possible, when you're working deep in the ear, against the bony part of the ear canal, which we are here because it's fully compressed around the sides, I always try and do suction first, because with suction you can try and remove the the wax without coming in close proximity, or indeed any contact being made at all with the bony part of the ear canal. With instrumentation, when it's fully blocked, you're going to have to go very, very close. And with the ear hook and the correct, for example, you are going to have to go in and behind and make contact. With the earpick, it opens up a slightly new avenue because you can glide, and it's the way it's been designed because it's got a small surface area. It's hardly felt by the patient. And the tip is slightly curved itself. So when you're gliding it against the canal wall, the tip, the pointed bit, is angling away against the canal wall. You've got to make sure you hold it in the correct orientation, of course. But also you can actually kind of almost dig into the wax because it's got that pointed tapered tip. So you can go close to the canal wall without fully going and kind of embed the tip in and almost chisel it out. So making good progress here. This last bit, you can see it's really large, it's really dry. It's a lot of keratin here as well, a lot of dead skin. Now, the majority of earwax is actually made up of keratin. And when we say keratin, keratin is a protein. We also find it on our hair and our fingernails. And the outer layer of skin that's lining the ear canal, in fact, most of your body, is actually a dead layer of skin. And in the case of the ear, the outer layer of skin is filled with keratin. So the keratin provides that outer stratum corneum layer with the rigidity. So remember, your ear, or probably more external parts of your skin, because the ear is obviously a cul-de-sac. So unless you're wearing hearing aids or poking around in your ear, you're not really going to put any physical stress on that outer stratum corneum layer of skin or the epidermis. But the keratin, nonetheless, provides it with some strength and rigidity. It also helps to repel harmful UV rays. And keratin actually is 40% hydrophilic, something else I just learnt recently, but 60% hydrophobic. So this outer layer of skin, it's just amazing, the physiology of it. It's just this fine balancing act of absorbing enough moisture from the air that enters the ear to keep the outer epidermis layer hydrated, but not overly so. Because if you do overly absorb too much moisture, then you can get a maceration of the skin cells, and it actually ends up leaving the skin more dry because there's inside the skin cells, alongside the keratin, you've got these natural moisturizing factors. They're predominantly acids. You've got amino acids, you've got carboxylic acid, uric acid, and they're hygroscopic, so they absorb and swell moisture, and they're hydrophilic. But if you have too much moisture in there, they dissolve within the corneocyte, which is the outer skin cell, the dead skin cell, which then means that particular skin cell is not able to absorb any moisture thereafter. So it's such a fine balancing act. It's just amazing how sophisticated the physiology of the ear itself is. So we can see we just got a bit of dry skin on the canal wall there. I'm going to just peel that away. Let's just pinch it off the centre of the eardrum. You can just see how narrow the patient's ear canal is. So we're having to go in, stretch the ear canal ajar so I can get the instrument in. And we're working on the anterior part of the ear canal here. So just gently obtaining a bit of suction grip and then peeling this keratin away. And slowly but surely, it's quite this texture of this remaining skin there was almost like a shard of glass. It was really, the ends were very jagged and pointed and very abrasive, almost like sandpaper. So we can visualize the eardrum. The patient can hear significantly better, but whilst I'm here, I just want to see if I can get this last bit out there, which I'm happy with. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.